Good morning, Susan. Can you hear me?
Yes, I can.
Is Robin here?
She is. Yes.
Okay, great. Okay. Yeah, there she is. Good morning, Robin. All right, it looks like we have everyone. I'll call to order the Green Mountain Care Board's meeting of December 6th. Today we have 3 agenda items. We have the Green Mountain Care Board staff analysis of OneCare's fiscal year 24 budget. And we have potential votes noticed on the Medicare only ACO fiscal year 24 budgets for Lower Health and Vitalize Health 9. Our health policy project director, Michelle Sawyer, and our staff attorney, Russ McCracken, will lead those presentations. And we'll have public comment after the OneCare presentation, and then a second round after the Lower Health and Vitalize presentations. I'll turn to our executive director, Susan Barrett, for her report.
Thank you, Mr. Chair. Wanted to remind folks about some public comment periods we have open right now. And also just to remind everybody that we accept public comment 365 days a year, but we do take the opportunity to make special public comments so that the public can share their views with the board ahead of a decision or a vote. So a new one that we just posted yesterday was the Brattleboro Retreats budget submission. This is a new duty for the board, and that they have their FY24 hospital budget review and materials that are posted on the board, and we'll be reviewing that on Wednesday, December 20th. We ask that folks share those comments so that they can be reviewed by the board, and if you could get those in by December 18th. If you get them in a little later, that's okay, but we are trying to have a time limit so the board can see those before they make their decisions. We also have an ongoing public comment period for OneCare Vermont's ACO budget submission and certification. And we would like to have those public comments into us by Friday, December 15th, so that the board can have those before their potential vote, which is scheduled for December 20th. And then we have 2 ongoing public comment periods on some work we're doing at the state. The first one is the Act 167 community engagement work. We finished up our first round of virtual engagement meetings and getting ready to go back out later this next year, early spring, to meet with community members in person. But we are accepting any public comments on that work. And again, thank everyone, providers and the public, for your robust participation in that work. And then lastly, we are accepting public comments on a next potential all-payer model with CMS. Any of the comments that we received, we share with AHS, Agency of Human Services, as they are leading the negotiations on that model and the work on the current model. And I just also remind folks to just check out our website for upcoming meetings. We have a couple of days that are starting early today. So just be aware of that schedule. And with that, I'll turn it back to you, Mr. Chair.
Thank you. There may be times I have to go off camera. I've lost my temporary office that I was using, and my internet might be a little iffy at times. So if I do, that's why, and I apologize. It helps with the bandwidth. We have meeting minutes from November 29th, 2023. Is there a motion to approve the minutes?
So moved.
Second.
All those in favor, please say aye.
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 Aye, and the minutes are unanimously approved. And is Michelle Sawyer here?
Yes, I am.
Hey, good morning. Remind me, are we doing One Care first or the Medicare only ACOs?
Yes, we're looking at One Care this morning.
Okay, great. All right. So the staff today will go through the presentation that they have in their analysis of the budget and the information we've been receiving over the last month or so. The board, I think, will vote on this. I think around December 20th is when we're planning on it. The staff will have a series of options for the board to consider and think about in advance of that, which I think will be at the end of this presentation today. So thank you, Michelle and Russ and your team and Angela for all your great work on this, and I'll turn it over to you.
Thank you. Good morning, everyone. Thank you for being here. All right, let's dive in. So here's the agenda for this morning. We'll do an introduction and background. We'll touch on some public comment that we've received to date. And then we'll get into the good stuff. We'll look at One Care Vermont's budget. We'll look at their budget targets, financial and performance review. And as Chair Foster mentioned, there's some options that will be discussed. Of course, there'll be time for board questions and discussions, as well as public comment. So I'm going to hand it over to Russ to give us an overview of the board's authority when it comes to the oversight of accountable care organizations.
Thank you, Michelle. So I'll speak about the board's oversight of ACOs broadly, and then some of the specifics around the review of certified ACOs like One Care Vermont. Generally speaking, the board's ACO oversight breaks down into two different functions. The first is certification, which is required initially for any ACO receiving state Medicaid or commercial payments. That happens once, and then it's reviewed on an ongoing basis, at least every year, and the staff is working on that process. The second is annually. There's a budget review for each ACO, and that takes place now in the fall, and the board will vote to modify or approve a budget before the end of the year. So next slide, Michelle. In looking at the budget review for a certified ACO like One Care Vermont, we look to the board's ACO oversight statute, its ACO oversight rule, and then the all-payer model agreement. Kind of the specific standards that have been adopted by the board reside in Rule 5405. It says for a certified ACO with more than 10,000 lives in the state, the board will consider any benchmarks established under the rule. The criteria listed in the statute in B1, I believe there are around 16 different factors listed there. Unlike the smaller ACOs, for larger ACOs, the board covers, the board doesn't have discretion as to which factors it considers. The rule says the board shall consider all the factors. The rule also says the board will consider elements of the payer-specific programs and applicable requirements of 9551 or the all-payer model agreement. And then lastly, any issues at the discretion of the board. And also, as set out in the rule, the ACO has the burden of justifying its proposed budget to the board. I know that all the board members have been through this process before for One Care, but hopefully that's a somewhat useful, if very high level, overview of the standards in the process set out in the statute and rule.
Russ. So let's just take a look at the timeline as far as OneCare's budget and certification for FY24. The board issued the budget guidance back in July. We received OneCare's certification eligibility verification materials September 1st. And like Russ mentioned, the staff is still working on that. OneCare submitted their budget October 2nd. We heard from OneCare Vermont at their hearing on November 8th. And then last week, we heard from the payers regarding 2022 financial settlement and quality performance. And then today, we're here to talk about the staff presentation for OneCare Vermont's budget. Next week, there's the potential for some deliberations on the budget, and there will be the FY24 Medicare benchmark presentation. On December 20th, there's time for a potential vote for OneCare Vermont's budget, and there's a potential vote on the FY24 Medicare benchmark. And then throughout 2024 and into 2025, the Green Mountain Care Board will monitor FY24 performance against the budget and conditions. So let's look at some public comments. So as mentioned by Susan, the public comment period is still open. It is open through December 15th, and we welcome any and all public comment. Thus far, we've received 12 public comments, and here are some themes that we're seeing. So we hear about the value of OneCare's improved health outcomes, higher quality care, lower cost, and enhanced coordination of care, the value of care coordination and strengthened partnerships with local care organizations. We heard concerns about access to care and long wait times to see providers. We heard about concerns about the cost of healthcare in Vermont and concerns about the effectiveness of OneCare, the loss of Blue Cross Blue Shield, and increasing executive salaries. The healthcare advocate also shared a public comment, which I would like to review. So they asked some questions. They're questioning if OneCare is providing sufficient value to Vermonters given its cost. They question whether OneCare's approach and place in the overall healthcare reform effort could achieve progress on the goals of the all-payer model, and if OneCare will be able to help achieve Vermont's healthcare reform goals. They expressed concerns due to commercial insurance rate increases in Vermont and the fact that they now far outpace the the United States average. They're concerned that Vermont's rate of underinsurance among Vermont's privately insured residents has increased from 27.3% to 44%. And Vermont's hospital adjusted expenses per inpatient day are now growing faster than the national average. They expressed they felt there was misrepresentation of the NORC evaluation to the board, the HCA, and the public. They expressed concern around declining population health management expenditures while observing increasing expenditures on consulting and payroll, and concerns about the purpose and benefits of Arcadia. The healthcare advocate provided some recommendations to the board. Those three recommendations are they are requesting that the board reduce OneCare's purchased services line by 50% and evenly reallocate those funds to non-hospital owned independent PCPs to improve primary care. The HCA believes that such a change is warranted because OneCare has not provided evidence of why this amount is needed. And that there is substantial evidence that independent primary care practices provide high quality and comparatively lower cost, and Vermont has historically underinvested in primary care compared to the rest of the country. They also request that the board and its staff conduct a comparative analysis of return on investment of OneCare's activities to non-Chittenden County-based HSAs compared to Chittenden County HSA. And they request that the Green Mountain Care Board and its staff conduct an analysis of OneCare's impact on affordability, health outcomes, and access to help inform whether OneCare merits inclusion in any future all-payer model. All right, so we will get into OneCare Vermont and the FY24 budget targets. So where we've been heading with these targets. So the FY22 and 23 budget order conditions reflected a focus on data-driven monitoring and oversight There's really a focus on ensuring that the ACO's management drives continuous improvement consistent with high-performing ACOs and that it supports achieving the state's health reform goals. This approach continues, and it led to the development of the budget targets in the FY24 budget guidance. As Russ mentioned, the board authority to set benchmarks, we use the word target in this case because the term benchmark has several different meanings in this world. But so for clarity, we're calling them targets. But this is outlined in Rule 5.402. The board may establish benchmarks for any indicators to be used by ACOs in developing and preparing their proposed budgets. They are really intended to signal to the ACO what the board would like to see in their submitted budget. The board developed 7 budget targets for this year, and there were 2 placeholders that were included as part of their guidance. And here's just a quote to explain how this works. If the ACO's proposed budget varies from the budget target, the board will review the ACO's proposed budget and support for varying from these targets in its FY24 budget submission using the factors and criteria set out in statute and rule. For all budget targets that are met, the ACO should expect less analysis of the area of the budget from the Green Mountain Care Board and staff. So in other words, these budget targets are not binding. There was no requirement that OneCare had to meet any of these targets. There's a lot on this slide, but I wanted to have all of the targets and their status in one place. We will take the time to go through each one. So just briefly, targets 1 is at least partially met. We're waiting on additional information. Target 2 was met. Target 3 and 4 were not met. Target 5 was met. 6 and 7 were placeholders that did not end up being developed. 8 was met and 9 was met. So we'll walk through. We'll start with target 1, which is the FY24 commercial benchmark trend rates must be consistent with the ACO attributed population and the Green Mountain Care Board approved rate filings. This target was met at least for the MVP payer program, and it's self-funded is to be determined. So this slide reviews all the payer programs trend and how the payer programs trend and benchmarks are set. We're focusing on the MVP and QHP and the self-funded payer programs for the sake of target 1. For the MVP QHP, OneCare shared that their benchmark trend rates were consistent with the GMCB approved rate filing. And for the self-funded, the submitted budget explains that OneCare is analyzing the cost trends in more depth over the next few months, and insights after this process can be shared as needed. And this table shows the expected cost of care for FY23 and the benchmark for 2024, as well as the budgeted trend from base experience for the payer programs. Onward to target 2. OneCare, let's see. The ACO must use best efforts to meet or exceed the goals for reconciled and unreconciled FPP and identify and report specific obstacles to achieving the goals. So the goals for Medicaid were 55% FPP and commercial 24% FPP. These were goals that the board had set for OneCare. Was the target met? Yes. For FY23 and anticipated for 24, Medicaid is approximately is over that target. It's over 55%. For commercial, it is 0. Just to be clear, this target is not that they meet the goal, it's that they use their best efforts to do so and report specific obstacles to achieving these goals. So even though they did not meet the target with commercial, they did report their best efforts and obstacles. They described that they continue to negotiate with commercial payers to implement unreconciled fixed payment models. Obviously, this is a two-sided negotiation and both parties must agree on the terms. The slide shows the expected cost of care in the columns from 2018 through 2024. And each column is broken into fee for service and then FPP and CPR payments. The blue represents the portion of the expected total cost of care that's fee for service, and the green is that FPP CPR payment. And then the line is the percentage of the expected total cost of care that is in FPP. So you can see that it has varied quite a bit over the years. But for 2024, it looks like overall 44.2% of all of the payments in expected total cost of care would be FPP CPR payments. And then this shows the targets and where OneCare has been over the years from 2018 through 2024. So if we start down at the bottom with the gray line, we see the commercial has been almost zero the whole time. There was a few years where there was a small amount of fixed prospective payments offered by a commercial program, but we're back down to 0% for 2024. And then the dotted green line represents that goal of 24%. The blue line is the Medicare amount of a fixed prospective payment. There is no goal surrounding that. The green dotted line is the 55% goal for Medicaid, and you can see that that the solid green line has been above that the whole time. So the FPP target for Medicaid has been successfully met. All right, so targets 3 and 4. Number 3 was the ACO must hold 100% of the Medicare Advanced Shared Savings dollars at risk at the entity level and not pass the risk along to the provider networks. This target is a continuation of a multi-year effort to have OneCare hold these dollars at risk. Last year, as a glide path to this target, the board had OneCare hold approximately between 30 and 40% of these dollars at the entity level, with the intention that this year they would hold 100%. OneCare chose not to do this. They are holding approximately 8.8% of those dollars at risk at the entity level, and the rest of those dollars are distributed as risk throughout the network. The 4th target was to increase risk corridors for all payer programs above FY23 levels, and the target was not met in this budget submission, and the risk corridors remain static between 23 and 24. So regarding target number 3, this slide shows budgeted risk from 2019 through 2024. And the percent of risk held at the entity level versus the risk delegated to the provider network. It's nice to look back pre-pandemic to see what these risk levels were and how they were significantly lowered during the pandemic. So for FY24, you can see that the total risk level is back up to pre-pandemic levels. But the OCV held portion of the risk is quite a bit lower still. For context, OneCare typically is taken on risk as a glide path to support HSAs who are newly joining payer programs. This was back in their earlier years when those HSAs were not ready to take on the full risk level in their first year in the program. And you can see in FY23 that OneCare's risk increased after they held a portion of those Medicare Advanced Shared Savings dollars. But in 2024, instead of holding more risk, they reverted back down to lower levels. This is for budget target 4. These are risk corridors over time in the public payer programs. So you can see in the Medicare pre-pandemic, it was up at 5%. And then during the pandemic years, it was knocked down to 2%. And then the last 2 years, it's back to 3%. And Medicaid, similarly, at one point, we'd gotten up to 4%, but we're back down. Then it got knocked down to 2% and 1% for the expanded cohort. And now we've been at 3% for a couple of years now. So we had, like I said, asked OneCare to expand those for 2024. Target number 5. The ratio of operating expenses to PHM or payment reform payments, which include FPP and budgeted bonus payments, must not exceed the 5-year average of 3.25. Is the target met? Yes. That ratio is at 3.1%. I know it shows the 5-year average is off by a couple of hundredths of a percent here, but you can see over time what that ratio has been and where we are for FY24. Higher than the years before, but definitely lower than 2018, 2019. Target 6 and 7, the board had considered adding targets for these areas, but the requested information from OneCare to inform these targets was not provided. So the board decided rather than set a target without the information that they would be left as placeholders. Target number 8, the ratio of population health management funding to the number of attributed lives must be at a minimum of the FY23 revised budget amount. Specific line items may vary upon any internal evaluation of the effectiveness of the individual PHM programs. The ACO, and then there's a second part to this, the ACO must propose a plan to increase the accountability of its provider network for quality. Examples for increased accountability could include adding in an adjustment to the hospital fixed payments for quality or increasing the ratio of the PHM bonus payments to base payments for primary care and community providers. Was this target met? Yes, it was. The population health management funding per attributed life is at $166 per life. And the staff found that the accountability for the providers was increased through increasing the ratio of the PHM bonus payments to base payments and the addition of network provider accountabilities to the provider contracts. So I just do want to note that the population health spending line does include the Medicare Advanced Shared Savings dollars. There are different ways of looking at population health support. So just to be clear that those dollars are included in this ratio. Let's see. So you can see that it outlines the changes in the number of attributed lives over the course of the ACO's operations, the amount of population health spending and the operating expenses in each one of those years, and then calculating how many dollars per attributed life were spent on both population health spending and operational expenses. And for the sake of this budget target, we are looking at that middle row and the column on the right, that $166 is higher than the projected 2023, which is $134. So they met this budget target. The second half of that target was around increasing accountabilities. So this reviews the network accountabilities that OneCare introduced to their network this year. All of the participating providers need to, when they sign their contract, they're also agreeing to meet these accountabilities. So these accountabilities include 6 different areas, the first one being technology. Participants are expected to implement and utilize an electronic health record that's compatible with CMD 2015 certification standards on or before January 1st, 2025. About 10 TINs that have historically participated in OneCare do not or may not meet the cert requirements. When we asked OneCare about this, they had established that about 4 do not have EHRs at all, and that 6 they hadn't received a response back from. They are not providing any financial support for these practices to upgrade their technology. The second one is care model. Maintain alignment with OneCare's care model and actively pursue attaining 75th percentile or more in 50% or more of PHM quality metrics in 2024 and 85th percentile and 75% or more in 2025. The third one, health equity, incorporates social determinants of health screening into yearly patient visits. Beginning July 1st, 2024, electronically report those SDOH screening rates to OneCare and develop a plan to collaborate to systemically address gaps in care by July 1st, 2024. The fourth one, engagement, participate in 50% or more of OneCare's value-based care related meetings annually. Citizenship, commit to OneCare's organizational values, which include collaboration, excellence, innovation, equity, and communication. And finally, cost and quality performance, perform at or above the OneCare target performance level on follow-up after emergency department visits for individuals with high risk, multiple chronic conditions. I think I may have skipped. All right, I may be missing a slide. I apologize.
So would you mind going back to 25 and walking us through the bottom of that slide?
Sure, absolutely. So this the bottom of this slide is the operating expenses per attributed life. You can see at the beginning as attribution was much lower. It's to be expected that getting something up and running, that your operating expenses are going to be higher before you have all of your attributed lives on board. It went down during 2020, 2021, 2022 as attribution was increasing. And then with the loss of the Blue Cross Blue Shield payer program, you can see quite a drop in attribution between 2022 and 2023. It really changed that ratio. So we went from $61 per attributed life up to $75 per attributed life. And then in 2024, again, we see another drop in attribution, and that is due to the Medicaid redeterminations. So that is why that, in addition to increased operating expenses, why that dollar amount is higher down in that bottom right. Okay.
Thank you.
Sure. And it does seem that I'm missing a slide, but I had mentioned that another way that OneCare increased their provider accountability was to change the ratio of their PHM payments to increase the bonus payment that the provider can earn by performing higher in their PHM measures. So overall, the potential payments to providers increased from 23 to 24, but the base payment actually decreased. So just practicing status quo, just reporting on care coordination, providers would actually earn less in 2024. But if they really work hard to shake things up and improve outcomes, they are eligible for a higher payment than they earned last year. Okay, target 9, this is the last target. This is regarding the March 2023 Medicare benchmarking report. We asked that where OneCare ranks below the 10th percentile among national ACO cohort or metrics where the trend has shown a decrease in performance between the years of 2019 and 2021. Choose 3 metrics that the ACO will address through the quality evaluation and improvement plan. The ACO should use metrics on which the ACO's provider network has the most influence on the outcomes and should justify their choice of said metrics. This target has been met. They chose 3 targets: ED utilization, annual wellness visits, and the number of beneficiaries with a primary care visit. And just to be clear, these are for Medicare beneficiaries. Here are just some snippets of OneCare's performance in these 3 different areas. OneCare is the dotted line there. For ED visits, you can see that it looks like they're above, but you want it lower, right, in this particular instance. So they are not even at the 10th percentile, so there's a lot of room for improvement there. The percent of members with an annual wellness visit, they are pretty close to the 10th percentile. Again, a lot of room for improvement. And then percent of members with a primary care visit OneCare is coming in below the 10th percentile. So they are incentivizing their network to improve these metrics through a few different ways. They are using the PHM measures so that providers, in order to get that bonus payment, they have to perform well on these measures. So potentially avoidable ED visits and wellness visits for folks who are 40 years and older. And then also we saw with the network accountabilities, there was one around their performance on ED utilization among folks with chronic conditions. They also, their performance incentive pool, which is another way for HSAs to be rewarded for high performance. Those dollars are doled out to HSAs that have lower ED utilization. Okay, so those are the targets. What was met, what wasn't met. Now we're going to look at some of their finances and their performance. So this is a very high-level overview. I just wanted to review that we can look at the budget in two different ways. The full accountability or total cost of care budget is in the purple, and then the entity level or organizational level budget is in orange. So the full accountability budget submitted is the result of provider network participation, negotiated payer program terms, and OneCare strategies to develop their network payer programs. It includes healthcare spending for OneCare attributed lives, for total cost of care services that are processed externally to OneCare. So that's 96%. So it's all the dollars flowing through OneCare to provide care. It also includes a small amount of population health expenses, just 2.5%, and then administrative expenses at 1.5%. So the full accountability budget is reviewed and approved by the OneCare Board of Managers, but OneCare cannot unilaterally decide the contract terms with payers, such as payment models, benchmark trend rates, and risk arrangements. The entity level submitted is developed at the discretion of the OneCare governance and leadership, meaning that it is elements of the budget that are not contractually obligated and are developed through committees made up of the provider network, supported by OneCare staff and leadership, and approved by their board of managers. Revenues that are not contractually obligated with payers include participation fees from the hospitals, fixed payment allocations, which also come from the hospitals, and shared savings distribution, which is set in policy by OneCare. Expenses include the PHM investments, administrative expenses, and shared losses, if there are any. If you won't see shared savings and losses in their budget because OneCare budgets as break even, meaning that they budget to hit their targets exactly, including the advanced shared savings dollars that fund the blueprint. All right, here is a view of their summary income statement. There is a lot here. So I want to point out what years we're looking at with this view. We have 2018 actuals, we have 2023 projected, and we have the 2024 budget. To the right of that, we have the delta between 2023 and 2024, and then we also have a delta between 2018 and 2024. So we can really see long-term how specific line items have changed. All right, so, oops, I apologize. Okay, so I would ask the board to look at the subtotal of operating expenses, which is about 2/3 of the way down. In 2018, you can see that it was at $13.7 million, and then for 2024, it's up at $14.29 million, which is an increase of about 4% over time. And then let's look at specifically what makes up that those operating expenses. So for salaries and benefits, we have in 2018, it was at 7.3 million. And then for 2024, we're up to 8.1 million. That is an 11.5% increase over time. regarding contracted and purchased services, that line item has jumped a lot. It's jumped from 1.7 million up to over 4 million, which is an increase of 147.7 million. Some of that story can be told because if you look at the software line has decreased considerably over time, and that's due to the transition to Arcadia, where they are now contracting with UVM Health Network to provide those services for them. So just overall wanted to point out that how those specific line items have changed over time. And then this slide just shows that the state has invested some money over time, especially in the earlier years, to get the ACO off the ground. They had OneCare had told us that, you know, in 2022, the loss of this funding was significant for them. Sometimes these monies also involved a federal match. So they were receiving quite a bit of support earlier on in their program from both the state and federal governments. Okay, so we're going to pivot to performance review. So how do we measure success of OneCare, and what data do we have to measure success? There are 4 different data points that we look at. We look at the quality and financial results, those annual payer contract scorecards. We heard about 22 performance last week. We look at the Medicare benchmarking report that OneCare is now submitting to the board twice a year. We look at OneCare's performance of their own PHM measures, as well as their performance on their key performance indicators. So, and I just want to say that even for the highest performing ACO, we would expect to see mixed results, areas of high and low performance, but these measures will help guide our focus as regulators, and should similarly focus OneCare as well. So this is, we're looking at payer program results, their quality results from 2018 through 2022. Like I said, 2022 were presented, the results were presented to the board last Wednesday, November 29th. So we have five data points now. Comparability can be a challenge given several factors. Difference in Medicare program quality framework in 2018 was much different than what it is now. The introduction of Medicaid expanded attribution, the public health emergency. You also should consider scale growth in each payer program over time and potential impacts on results. But the numbers, I think, speak for themselves. At face value, it seems pretty simple, but there's definitely, it's a nuanced thing. The next is the financial results. This slide might be a little confusing. The numbers in parentheses are savings. They're in parentheses because they are under the target. So in this case, the numbers in parentheses denote shared savings. So we have 2018 through 2023 projected, and and then over on the right, we have the same table, but we took out 2020 because that was a very unique year with the public health emergency, and people weren't able to access the care that they usually would. So you can see that Medicare is a clear winner in the story. Year over year, Vermont comes in under the Medicare target, which seems great, right? So there's a couple of points that I just want to make. This can't be, there are multiple factors that should be considered as to why we come in under the Medicare benchmark. Part of it could be OneCare, but there are other factors. There are factors like the blueprint. The target itself is a negotiated number. So sometimes, you know, if you're able to negotiate a favorable number, that makes it easier. The other thing I think about when I look at the savings in Medicare is the fact that the risk corridors are so small that we're really leaving a lot of money on the table. If those risk corridors had been larger over time, we would have been able to take home a lot more of those savings. We can also think about the sources of participation fees that the hospitals pay into OneCare, which is really the primary source of how OneCare keeps its doors open, is through these hospital participation fees. We hear from hospitals that they are not able to break even with Medicare and Medicaid payments. So it's really the commercial payments that are keeping these hospitals going and must be ultimately paying these participation fees. So when there are Medicare savings, only a portion of that savings is actually paid out to the ACO network because of the risk arrangement, as I said. So Medicare gets to keep the rest of those savings. And if the ACO is saving Medicare money, but at the expense of commercial funds and the Vermonters who pay for those commercial, very high premiums and deductibles, it's just something to consider about the system. I think it's possible to frame it as commercial payers and Vermonters who are paying for those as kind of subsidizing this program and success, the success we're seeing in the Medicare program as well. The other thing I want to look at was the benchmarking report. This is a subset of measures that we look at that we have been advised that ACOs have particular control over. They include ambulatory care sensitive admissions. It includes total cost of care, emergency room visits, and primary care utilization. So this shows performance of OneCare between 2019 and 2022. There's a handful of these that are inverse. I'll just throw that out there. And I think it's not a full picture because we don't have a national cohort on the slide to compare trends with. So it could be a national trend and not necessarily just a OneCare in a vacuum performance. But I wanted to show this for general. You can see the trend lines on the right and generally see kind of a mixed bag of outcomes. And you can see, especially primary care here as kind of appears down at the bottom, and those have just been declining since 2019. So as far as the PHM measure and KPI performance, there's a lot of overlap with these metrics for OneCare, so I put them all on the same slide. So I have the measures, I have the 2023 target that they have set for their network. They provided the progress of their network through March 2023, so just really Q1 performance on these metrics and whether their target, their self-imposed target, has been met by their network during Q1. So for child and adolescent WellCare visits, the target is 57.5, and right now network-wide, or I should say back then, earlier in the year, they were at 57.2, but 40% of their practices were meeting that target. Developmental screening, the target is 57.4%. Network-wide, they're at 60.4%, and 40% of practices were meeting that target, so that target was being met at that time. For diabetes A1C poor control, the target is 39.9%. When they submitted, 97% of practices were meeting this target, and they said it was to be determined, but things look bright to the point that OneCare is removing this metric from their 2024 PHM measures because they feel as though the network has made a lot of progress in this area, and they've kind of topped out with their performance. Regarding initial hypertension, this is an HSA specific metric. So it is, there's no set number. They're expecting an HSA to look at their score and then improve by 10%. So if your HSA was at 40%, let's say, it's expected that you would go to 44%. In the first quarter, 1 of 14 HSAs were meeting that target. For routine hypertension, again, a 10% improvement. First quarter, 5 of the 14 HSAs were meeting that target. Annual wellness visits, 40 plus. In the first quarter, 19% of practices were meeting the target, but at the HSA level, none of them were meeting that target yet. And then the final one is not a PHM measure. It is just a KPI, which is a potentially avoidable ED visits. And they were looking again for 10% improvement by HSA, and 33% were making that improvement so far. All right. I wanted to also touch on OneCare support for primary care, as this is a consideration in statute that the board must examine as part of reviewing their budget of an ACO. Overall, the funding through population health efforts per attributed life has increased since 2022. Because this, and so you can see that here in this middle row, per life, it has increased per life. I'm sorry, the ratio has increased over time. So in 2022, for every attributed life, there was $71 of population health. And I just want to note what this number includes and doesn't include, because as I mentioned, population health payments can be looked at in a few different ways. But in this analysis, it doesn't include FPP or fee for service. So I just wanted to note that. So it's the ratios have increased over time, but these dollars are linked to attribution. So between 2022 and 2024, we've seen quite a drop in attribution. So the total amount going to primary care has dropped from 16.1 million down to 12.7 million. And I think it's easy to say that, you know, more per life is going, and when these dollars are linked to attribution, it's like they're doing all they can to support these primary care physicians or programs, given the number of attributed lives they have. I think the one point I'll make is that these practices are still seeing the same patients. It's just fewer of them are attributed to OneCare. So they are still providing the same care for patients. They're just not receiving as many support payments to care for these patients and to innovate and to hire additional staff. So it's, I think this shows that tying these dollars to attribution is challenging. For the practices, as attribution has shrunk. Okay, so these are the options for budget modification and approval. I will read through each one, and then we'll move on, but we can always come back to this slide. So the first one is to fund OneCare's budget as submitted with any or all reporting conditions as outlined in the following slides, which we will review. Number 2 is the same as number 1, plus a new condition that OneCare must hold the Medicare Advanced Shared Savings dollars as risk at the entity level unless they increase the Medicare risk corridor for FY24. Third option, reduce OneCare's salary and purchase services from 12.5 million to the 2018 level of 7.4 million. And evenly reallocate these funds to non-hospital owned independent primary practices to improve primary care, including the additional conditions regarding reporting with or without that risk option. Fourth option, reduce OneCare's administrative expenses from 14.3 million to the 2018 level of 13.7 million and evenly reallocate these funds to non-hospital owned independent primary care practices to improve primary care, including additional conditions regarding reporting with or without risk options. Number 5, reduce OneCare's administrative expenses from 14.3 million to 11.6 million in order to maintain the ratio of administrative expenses to attributed lives at the 2023 level of $75 per life. You could also add the additional conditions, the reporting conditions with or without the risk option as well for that one. And the final one is one of the HCA's recommendations. Reduce OneCare's purchase services line by 50%, which is currently at 4.3 million, and evenly reallocate these funds to hospital-owned independent primary care practices to improve primary care. And then you could add additional conditions regarding reporting with or without the risk option I described in number 2. That's a lot to think about. I will come back to the slide. I want to walk you through the reporting conditions to consider. So these conditions are consistent with previous years. OneCare would notify the board of any material changes to their budget and explain any variance. Submit a revised budget by March 31st, 2024, and present on the revised budget in April 2024, including final payer contracts, attribution by payer, a revised budget, hospital dues and risk, and changes to the risk model, source of funds of population health programs. Third, notify the board of any use of reserves or line of credit or any adjustment to participation fees. Implement benchmark trend rates for payer contracts in alignment with the board's decision on the Medicare ACO benchmark. Our presentation on that is next week and the vote the following week. The GMCB's Medicaid advisory rate case and for commercial contracts in alignment with the ACO attributed population and the Green Mountain Care Board's approved rate filings. Fourth, the last one here, engage in payer programs that qualify for APM scale to the greatest extent possible and align payer programs in key areas to the extent reasonable. Explain non-scale qualifying programs and areas of misalignment. Require continued reporting on payer programs. These are also consistent with previous years. Fund population health management management and payment reform programs as detailed in the FY24 submission, or we may end up modifying possibly, and notify GMCB of any changes, including funding shortfalls, changes in program scope, and an analysis for each program line item as to whether and why the funding is appropriately scaled by attribution or some other factor. Report evaluation results and evaluation focus areas for 2024 to the board. Fund the Support and Services at Home, or SASH program, and the blueprint for health payments to primary care practices and community health teams consistent with the amount approved by the Green Mountain Care Board in the Medicare ACO benchmark process, which will be presented next week. These deliverables are pretty consistent, but I would like to perhaps update some of the conditions are consistent. I would like to update some of the deliverables. Work with the Medicare Advantage plans working in Vermont with a particular focus on Vermont-based programs offered by Blue Cross Blue Shield and the UVMMC MVP program to develop scale qualifying programs. Report FPP data and progress towards the goals as specified in the ACO reporting manual and 24 guidance. Report on their CPR program and make it some improvements to the benchmarking report, including a statistical significance analysis and a risk report on risk of all cohorts for each year. And then I included the new one that I mentioned in option number 2, OneCare to hold risk for all Medicare advanced shared savings dollars unless the Medicare risk corridor is increased above 3%. Just a quick timeline, seeing, there's a lot to think about, but we have 2 weeks before the potential vote and the potential to deliberate next Wednesday. That is all I have at this point. I will turn it back to you, Chair Foster, for any board discussion.
Great. Thank you, Ms. Sawyer. And just to be clear of the options that are presented and the potential conditions, the board can, of course, consider others as well. That's just a set for us to start thinking about in advance of the deliberations.
Absolutely.
Okay. I'll open up to any board member questions or comments.
Michelle, I had a question on something that you said related to the financial analysis. I thought I heard you say, and either you misspoke or I misheard, that Medicare benchmark was negotiated, which is not the case. The board sets the trend for the Medicare benchmark based on data that is provided by Lewin, which is Medicare's contractor. So I just wanted to circle back to that because I don't know if I heard you wrong, but that would be incorrect if that's what you said.
What you just said is my understanding as well. I apologize if I misspoke.
That's okay. I thought it was in relationship to whether or not the benchmark was like a reasonable target. So since we
That's
set
just
it,
for the commercial
Okay,
ones are negotiated, right?
right, that's true. Okay, thanks. Yeah, and there was some indication in the MVP discussion last week about their benchmark, not the risk adjustment in their benchmark, not adequately adjusting for actual risk. So that makes sense to me. Thank you for that clarification. I do have questions on could we go back to the recommendations? I guess I'll start there. So why are we picking 2018 in these specific numbers in 3 through 5?
That is a good question, Robin. This is what I heard as interest. These specific options. So I tried my best to deliver a series of options that fell in line with what I had heard was of interest to the board.
Okay, so maybe before we negotiate, the board members who had interest could articulate the why these years and why these numbers so that I can understand where it's coming from. I mean, obviously, people can choose to do that today or not, but I'm not seeing like the connections here. And I'll just tell you my other question. So why independent PCPs, which are 18 practices, as opposed to putting more money into other population health programs, which understandably would make it more diffuse, but would potentially have more impact on moving, if this is connected, for example, to a particular quality metric or something like that. I'm not sure if 18 practices have enough attribution to move the ACO-wide performance measure. So I just have a question about that in terms of like, I need somebody to connect the dots for me.
Sure, I can say a couple of things. So there are 18 practices that are enrolled in the CPR program, but there are more. I believe there's 24 approximately independent primary care practices that are part of the OneCare network, and just not all of them participate in the CPR. So that's one thing. The other is I believe, this was noted this way because of the quality of independent primary care and their ability to see patients. But I think that it would be a good place to discuss. And I don't think it's a hard and fast thing. It's just a starting point for discussion.
Could we get the evidence on the quality for these independent practices, these 24, so that we know that it matches whatever evidence you're referring to? So that's a question.
Okay.
Also, you had indicated on slide 38 that attribution is down, but that doesn't necessarily mean the primary care practice are seeing fewer patients. Do we have data on that? For example, we did hear in a public comment about a practice that had reduced their number of patients rather recently because of some staffing issues that they had. So how do we know that the practices are seeing the same number of patients?
I can certainly see if I can find that data and provide that, Robin.
Okay. I mean, it's not that big a deal. I just wasn't sure where that statement was coming from,
Sure.
given that we had that public comment previously. On the attribution generally, do we have any information on the current status of the Medicaid redetermination and how that's going? I would, to your point earlier, a big decrease in the attributed lives is related to the Medicaid redeterminations. The stats that I had seen early on from the DVHA website indicated a lot of that was paperwork, which is not unexpected. That's typically why people fall off during redeterminations. So I was just curious how that was going, if we have any information on whether or not they would expect some rebound. So for example, since Medicaid will pay retro 90 days, if somebody shows up at a hospital and the hospital's able to get them signed up again, so they can get paid for that day, that will help with bringing people back onto Medicaid. So just getting any sense of that might be a little helpful if we're going to be looking at per life targets.
Sure, we can reach out to DVHA between that and the attribution reporting that we receive from OneCare on a quarterly basis. I can try to get a clearer picture of what is happening currently.
Thank you. That background would be helpful. And then on the Medicare shared savings at risk at the entity level, why the connection to increasing the risk corridor? Like,
I'm
from
sorry.
my mind, let me just give you, so in my mind, the reason why we had suggested, at least my reason for why I had voted for the Medicare shared saving dollars being at risk at OneCare was because of solving the issue that we've heard from hospitals that they were perceiving the advanced shared savings as asymmetric risk. So that then I can't follow that through to increasing the risk corridor and how that would solve that problem, which is what I thought, at least for me, was the problem I was trying to solve with that. Now, I will say, I am of two minds on the risk at the OneCare level. There's a lot of unknowns, obviously, about where we will be moving forward in the future. And this is a big if, the state were to pursue and sign an agreement in the AHEAD model, the risk in that model is on the hospitals. So there's an argument that and obviously we don't know if we're going to do that or not. So this argument can go either way, but that if you wanted to prepare folks or you wanted people to be more prepared for holding risk, you would actually shift it onto the hospitals now so they get some experience of that over the next 2 years, should we move forward with that. Obviously, there's a lot of ifs there, but so that's just some initial thoughts on how I'm thinking about that and would love some discussion around that. I'm going to be quiet now and look at my notes and see if I had anything else and give other folks a chance to speak.
I can hop in for a couple questions. Can I just follow up with just a question coming from Robin's question? Could you provide an argument, Michelle, we sort of had the argument for why having more risk at the hospital level may have some advantages for potential future risk management? Could you provide an argument for why having OneCare risk
I'm having a hard time hearing you, Dr. Merman.
Oh.
Same.
Let me pass and then come up with a different solution.
Okay.
Michelle, can I add just a quick question? And this is actually a little bit following on if some of these recommendations are looking at a per life level, per attributed life level. Just one other question I had, and maybe this I have to go back to our slides originally. I'm trying to, it'd be helpful to unpack how much of the decline in attributed lives is also related to Medicare Advantage uptake. So I'm just kind of curious if we have those numbers as well. I know most of it is Blue Cross Blue Shield and the redeterminations, but if there is that data, that would be helpful to know. And I'm just, I guess I would say that I'm looking at these now, and it would be really helpful. I think this is on the agenda for next week, is to revisit. Have some deliberations and revisit, and it'd be really helpful for me to see pros and cons associated with these each of these options, and some assessment of intended and potentially unintended consequences of some of these. And so, if we can just have a little bit more context for the justifications, what we're hoping to achieve, and some of the downside risk of some of these proposed modifications would be helpful to me. And I'm going to obviously think about these for the next week. I may have some other ideas, and I'll bring them up next week if I have them. So, but I appreciate all the work that's gone into this.
Could I give another try?
Sure.
Okay, how's that? We have audio?
It's better.
Okay, thanks.
It's much better.
All right. Sorry about that. I have my old computer died. I have a new computer, and this is the maiden voyage here, and seems like I got some kinks to work out. So my question for you was that Robin talked about the potential advantages of having risk held at the hospital level, and I was wondering if you could just refresh me on the sort of the logic behind having that risk held at the ACO level, and what the board was trying to accomplish by doing that last year and potentially in the future.
Sure. As Robin said, a lot of we were hearing from hospitals that including those advanced shared savings dollars as downside risk, it really made the Medicare risk corridor appear to be asymmetrical. So the hospitals had to earn back those dollars before they could even really start looking at savings. There was more at loss than there really was. It set them behind in saving money. And I would say nationwide, it's pretty common to see ACOs at the entity level hold at least some risk. And so we thought that transitioning those dollars to the entity would both solve the asymmetrical risk corridor problem that we were hearing existed, and it would give OneCare some accountability as well.
Okay. So your recollection of or opinion on this would be more that it was for trying to alleviate that perceived risk by the hospitals with this advanced shared savings money, more than sort of the concept of like a skin in the game where the as an incentive to try to OneCare to try to figure out how to have more shared savings.
I think both of them played a factor, but I would say the former was the larger concern.
Okay. And I do want to thank you, by the way, just up front for like the tireless work that you've put into preparing and learning and presenting, and I really appreciate the hard work of the team and of you specifically. So I just had a few other questions. I think some of this will take a little bit of time to digest of what you presented, but have we received any information from OneCare about the request for trying to figure out the administrative cost by program? So what the various programs cost?
No, we had asked in the budget guidance for OneCare to provide that information, their budget broken out by program, but they said that's not how they do their budgets, so they were unable to be responsive to that request.
Okay. And then have you received, I hadn't seen, but have you received any information or had any other communications from OneCare regarding the variable compensation, specific and measurable goals that are in the Care Board's rule for the next year, or if we know how those are going to shake out for this budget?
No, I from my recollection, the corporate goals to which their variable executive compensation will be tied will either be determined by their board of managers later this month or potentially in January after the vote.
Okay. I think that's all I have for now. Thank you so much.
Hey, Michelle, it's Tom. I just want to also share my thanks for all the work. It's tremendously big lift. And I just have a couple questions. One, and I'm not sure they can be answered today, so I'm not trying to put anybody on the spot or require anything, but could we go to slide 25, please? So I'd like some help understanding how the numbers shown here compare to the HCA public comment. In the public comment, they had in their appendices, there were figures that showed declining public health payments over time and increasing, I think they said, payroll and consulting expenses, which I think would be rolled into operating expenses. These numbers seem, I'm having a hard time squaring these numbers. These numbers look like things are moving in a better direction from a OneCare perspective. And the HCA public comment didn't look as favorable for OneCare. And so I need some help, maybe from you and staff and from the HCA, to try to square these, at least in my mind, because I'm a little bit confused. And we can do it now, we can do it during the week, we can do it next week during deliberations. But I just had some trouble lining these things up. If there's an easy answer, I'd love to hear it now, but if we need to wait, can do that.
I can offer a brief explanation in that I believe what the HCA is considering population health spending is different from what we had traditionally presented. This table we've shown in previous presentations, and we felt it was important to keep it consistent. So in this particular slide, those dollars include the Medicare Advanced Shared Savings dollars. So that could be the difference between what the HCA is showing and what we're showing with this slide. But that's just off the top of my head, the first thing that I would flag. But we can, I think, have a good conversation about this and with the HCA.
Great. I see Dr. Schulteis is here too. So happy to hear from him now or at any time, but just trying to help me square these, that would be great.
Do you want me to answer, Tom? Like I have some rough things. I mean, I'm just thinking about other things that may be going on. I think Michelle is right about the methodology. If you look at I tried, perhaps unsuccessfully, in that there's a paragraph in that section where I go over how it's done. Looking at this, I think because of confidentiality concerns, we went with the budgeted numbers each year. We also excluded 18 because we felt it was, I felt it was unfair because of startup costs. So, I mean, that's kind of like a judgment call, right? Like whether we include 17 and 18 or just 18 or neither. And then I'm looking at this and I think part of the reason, and it, in terms of how their admin costs look, it looked better, but PHM didn't look bad, makes it look worse, is we put it in real dollars. And I think that's a general preference that I have for comparing financial numbers over time. So that's going to inflate the 2019 spend relative to the 2014 spend. You know, and then of course, as Michelle pointed out, it's what we're counting as PHM spend. So whether we're counting the blueprint, whether we're counting FPP, you know, I think I tried to do it similar to the PHM spend in the NORC report, which I wasn't able to perfectly replicate. It was a little unclear what data sources they were using. And then, you know, I also, with the caveat that I also excluded blueprint spend. So I guess all in all, I think it's just different looks. I wouldn't expect numbers to line up exactly because we're using relatively substantial different methods.
Okay. So just to couple follow-ups, if I could. When you say real dollars, should I take that to mean inflation adjusted to current day?
It's adjusted with CPI-U nationally for 2023. It's using the average of the existing 9 months of CPI-U as okay. I guess estimated, and then for 2024, it's using, well, at the time that I did this, the New Economists approach, the state economists hadn't released CPI-U projections, so it was using a CPI-U assumption for 2024 based on I think 2 years average. I spell it out in one of the footnotes. Okay. So definitely take a look at that. I have this bizarre love for footnotes. So it's in there somewhere.
I appreciate it. So there is basically trying to get it all to a current dollar amount best we can. And the rationale for leaving out the blueprint, I could imagine, correct me because I can also be wrong about these things, but leaving out the blueprint is to try to isolate the effect of OneCare.
I think that's true. I mean, I think a plausible argument could be made that, you know, you should include blueprint because of how the pass-through structure works and the reason we have OneCare. I think from my perspective, I felt like it was important to try to isolate what OneCare is doing that's new and not just what the blueprint is already doing. I think you probably could make the argument that but for OneCare, there would be no blueprint. Okay. But, you know, that was a choice.
Yeah, I appreciate your transparency with all that. Yeah, I think this has been really helpful, but I think they're not just small differences. Sometimes like the differences are directional, and so helping us all feel confident about how these things differ, I think would be good, because they have implications for the options that were outlined. I think 3, 5, and 6 would all depend on how deeply we understand this and the HCA analysis. Okay, there were hands that went up. I don't want to move on if other people want to participate.
Tom, we'll take public comment at the end.
Okay.
I thought one of our staff, Matt Sutter. Matt, did you have something? I saw your hand go up.
I did. I was just going to explain the difference and how we're calculating things, but Eric hit everything I was going to say.
Okay. Well, that's good.
We can provide a crosswalk kind of explaining the differences. Just the board next week.
That'd be great, Matt. Thank you. Could we go to slide 36, please? And this one, I wanted a little bit more time to look at. Personally, I don't have any trouble with inverse measures. Right? I just have to slow down and remind myself of what is the trend we're looking for. Some of these, the ED cost of care, total inpatient cost, primary care, they're concerning. A lot of the trends are concerning in this, and I will take some more time to look at it. It's not substantially different in my mind to what was presented last week regarding the quality performance, but this is a different way to look at it. And they're concerned, so I want to make sure that I'm understanding it. And finally, the next slide, please. Here, so in OneCare's presentation earlier in the fall, I don't remember who from OneCare, but they had mentioned a desire to stop tracking the proportion of patients with poorly controlled diabetes. And I remember at the time that the rationale for that was that their performance had topped out. It'd been the same year over year, and it gave me the impression during the meeting that they must be doing really well. And it surprised me because in the prior look at the proportion of patients with an A1C level greater than 9, the numbers hadn't been good. And here, diabetes A1C poor control, 39.9%. Correct me if I'm wrong. That means nearly 40% of patients with diabetes are poorly controlled. There's nowhere that that's a good performance. And 97% of practices meeting it isn't good performance. So I don't know if I'm reading it right, but that jumped
Tom,
out at me. Yeah.
Forgive me, and I'm going off of my memory right now, but the memory that I have from the prior presentation was those rates were in the 21, 22, and there was 1 year where it dropped to 11.4, but it was kind of mostly around the 20 to 23%. So I'm not sure if these are looking at that in a different way. It's probably, I'll stop there, but there were different numbers in that presentation that don't meet these. And so I wonder if we're just if it's just being looked at differently.
Sure. 20% is not a good number either, but I'd like to understand, this isn't a financial question, this is more of a performance question, but those numbers are concerning. And so I'd like to make sure that I understand that. Because if it's 20, 30, 40%, that measure should not be sunsetted. These are the patients who, patients with poorly controlled diabetes, with comorbid mood disorders, anxiety and depression, are the group that commonly have the most unplanned ED visits and inpatient admissions, and then surgical admissions as first their big toe is removed, then their foot is removed, then their lower leg is removed. So these are the patients that most ACOs are really trying to find the patients with rising risk in order to prevent those ED visits and admissions. So if the numbers are in the 20 to 40% range, they should not be sunsetted. Then just two more things. The ACO level risk that Dave and Robin were talking about, ACOs are commonly doing that. They're accepting oftentimes 100% of the risk. And the reason that we were talking last year about this ACO having some risk is that providers were telling us that they did not have the data in order to know what to do better in order to earn their shared savings, and that there were no programs from the ACO to help them address the care coordination, communication needs in order to improve care. So the providers were saying, we're not getting value from the ACO that would allow us to take more risk. So by shifting some risk onto the ACO, we were trying to say, give them more analytics, give them more programming that would help them better manage their patients, because that's what ACOs are supposed to do. Right? The ACO concept was providers should be sharing risk, not just payers, not just the Medicare, Medicaid programs, but providers should share risk also. In this particular case, there's, in my mind, justification for the ACO sharing some risk to improve its performance to help enable the providers to meet what they need to meet. And then with the modification options, these are not mutually exclusive, right? Like somebody could get all crazy and say, I want 2, 3, and 4. Right? Okay. And some new combinations possible. And I don't remember exactly why in last year's budget presentation, we were trying to determine what costs OneCare had that were fixed and what were variable. What costs should fluctuate depending on the volume of patients, attributable lives, and what you just need to run a shop. And I asked, when were you fully staffed to meet the fixed cost of running the shop? And the answer was 2018. That's all from me.
I have just a couple little comments and things to think about off of what some of the other board members said. One off of what Member Holmes said about sort of some of these options here and thinking about the pros and cons and other ways they can be thought of. I think over the next 2 weeks, we should work on that and see if there are other options we want or other ways to use the money. And if there's any things that we need to add to it to make sure it works effectively. So, you know, for example, with the population health money that went back to the hospitals, we don't have any real certainty or evidence at this point that it was used for those purposes. And so if we're going to use money in a different way in this budget, prove it differently, we should think about how we need to make sure that money will be used effectively. And also to Member Holmes's point, or maybe as Robin's, where we're putting it and why we should think about quite a bit. The other thing I would think about kind of at a large level is it's OneCare's burden to justify their budget. And it looks to me like over the 2018 to 2022 results that we have, the quality is rather inconsistent, flat, or even negative in some regards. Certainly not like a consistent trend line like we saw, you know, last week in the payer presentations we had. It didn't really look like it was defined or it could be really attributed to anything that OneCare was doing programmatically. And so if the results are sort of flat, how do we conceptualize that in light of their burden to justify their budget? And then the savings, I think that the point was well made that it could be based on targets, it could be based on performance, could be based on noise in the data, could be based on other healthcare reform efforts, could be based on demographics, any number of things. And so it looks to me like from the slides and the evidence that we received from OneCare that the savings, and I'll quote savings, is also somewhat inconsistent from year to year and payer to payer. And certainly as to the two buckets we're most interested in, I think for Vermont payers, Medicaid and commercial is not significant. And so thinking about those, how are we conceptualizing whether OneCare met its burden to justify its budget? Similarly with the administrative costs, I'm trying to think of what are we getting for these things? And this is a point I raised last year. Why are we putting why is OneCare putting certain amounts of dollars into some programs and other amounts into others? And is that the right mixture? I think at the time there wasn't really a clear answer on that. But if we don't have a data that I think the staff had asked for, Dr. Merman, about the administrative cost by program, I struggle with saying, okay, well, the whole budget in whole then is approved and they've met their burden, right? So if we don't know what programs are really working or having an impact to the positive for Vermont, I struggle with what the evidence is or justification is to satisfy the budget. And I guess I would say that in all candor, I'm a little bit vexed by the OneCare budgets. And I say that because there are some things in this year's budget that I liked quite a bit, that I thought were better. I thought the shift in the amount of the base being a little bit lower and the bonus being higher was beneficial. I thought some of the approach was a little bit improved overall. But really, it seems to me like the crux of the benefit of the OneCare program are some of the structural things, the money from the feds for Blueprint and SASH. And that's really just by mere existence rather than a programmatic effort. And then some of the waivers, that's beneficial. And some of the pass-through and redistribution of money to where we want it, I think is beneficial. So I'm trying to think about what those cost, and because I think those are justified because those are good. And then the others, it's sort of unclear if they're beneficial and or whether or not the burden's been met on those. So I'll leave it at that. I don't think I had any other. Oh, one question, Michelle, for you. On the state support slide, could you go back to that real quick? I think it was informatics support. Yeah, thank you. These funds, were they matched by the feds, did you say?
I believe in some years they weren't. I would have, or they were. I would have to get back to you with the details. I don't feel confident in saying definitively that they were matched every year.
Okay. And can you remind me why they dropped off in 22?
That may have been when the match expired. I don't want to say anything incorrect. It may be because the high-tech funding dried up at the end of 2021. Okay, Robin's nodding. So the high-tech program was a federal program to fund advancements in health information technology, and that program sunsetted at the end of 2021.
And then these funds were not, these are not part of the admin or operating expenses of OneCare. There are additional revenue in the budget that we see?
They are, yes, they would show up under the revenue.
Not as admin expenses. Right, because they're, right.
No,
Okay.
because this is money coming in, yeah.
Yeah. Okay, I had nothing else. Thank you very much to you and your team for this presentation today. It was a lot of work for sure. I'll turn to the healthcare advocate for any questions or comments they may have.
Morning. Also, thanks, Michelle, Russ, and Angela for all your hard work on this, and thanks for a great discussion this morning to all the board members. I think our comments, concerns, and recommendations were really well summarize. So thank you, Michelle. I think our concerns about relative declines in OneCare's PHM investments over time relative to some other expenses is a key concern to us. And to Member Walsh, thanks for your questions, and thanks to Eric for answering in real time about that. I think in general, there are some pretty consistent trends between what the board staff presented and what our analysis did. I think there can be some methodological differences, but I think it's reasonable to us to expect PHM to either, at least at a minimum, be consistent or increase over time. And that's not what we've seen, at least in our analysis, which leads us to question the level of value that the model provides to Vermonters. And I want to recognize that the board is in a tough position, having played a role establishing OneCare, but we believe that the next all-payer model agreement should present the board with an opportunity to really conduct its own analysis to kind of what you were getting at, Chair Foster, around return on investment. I think the board needs to do an analysis for itself and really decide about the future of OneCare and whether or not it makes sense to continue with the all-payer model or to consider alternative funding mechanisms. So thank you.
And I'll turn it to public comment via the raise the hand function. Ms. Wasserman, good morning. How are you?
I'm fine, thank you. I just have one quick question for the staff. One of the earlier slides, I don't have the number, talked about fixed perspective payment. If we could go to that slide, I'd be interested in understanding a little more clearly why Medicare is considered fixed perspective payment when in fact fixed perspective payment is also known as a capitated payment. And my understanding is that those fixed perspective payments to for Medicare, on behalf of Medicare, for the hospitals is reconciled at year's end. So my question is, why is that considered? Why are the Medicare payments considered fixed perspective payments?
Great question.
Ms. Sawyer, can I try?
Yeah.
Ms. Sawyer, can I try and jump in?
Absolutely.
So let me just ask the question that I think would be helpful, which is that correct that the Medicare fixed perspective payment is reconciled?
That is correct.
And are the others?
Medicaid is not. It is unreconciled.
And can you explain the rationale for that and why we include it here?
Well, the Medicare payments, even though they are reconciled at the end of the year to fee-for-service, they are still fixed prospective payments made to the providers. So that payment mechanism still falls under the definition of what a fixed perspective payment would be. Medicare has not expressed an interest in being involved in an unreconciled version of this, whereas negotiations with DVHA have resulted in the ability for the network to receive unreconciled fixed perspective payments, which allows providers to, if they overspend, if they spend more than their fixed payment was, then they're on the hook for somehow figuring out the difference. But if they spend less than the fixed perspective payments they receive for the Medicaid lives, then they get to keep the additional monies themselves. So does that answer your question?
Yeah, so just for like a simple example, if I am a physician and I have a Medicare patient, let's say 10 Medicare patients, through the course of the year, I get a capitated payment, and that reconciliation is at year's end.
Correct. That's my understanding.
And if my billings on a fee-for-service basis are greater than the capitated payment that I receive from Medicare, what happens?
You have to send that money back, and you are losing that money. That's my understanding.
Right. So my capitated payments are $100. My fee-for-service billings are $125.
Right. You only get to keep what you spent for fee for service, or yes, if you spend more than what you were allotted, then you have to. Now I'm getting confused, Owen.
You know what? I put you on the spot. We can get back to this. I think we can just briefly address this when we have a little bit of time to make sure we check the regs and the rules and make sure we have it right. So
yeah, I want to speak to it correctly.
Yeah, it makes sense. Any other public comment?
Yeah, I'd like to make a comment. My computer dropped out, so I didn't hear the discussion between Chair Foster and Michelle over the last couple minutes. But I guess what I would like to see is that the Medicare line be titled Advance Payments, because that's in essence what is occurring, is that the hospitals get advanced Medicare payments that are reconciled to fee-for-service at year's end. And I think a more accurate description is advanced payments as opposed to fixed prospective payments. It takes the term fixed prospective payments and dilutes it, which I don't think is helpful in this discussion. And again, I apologize for not being able to hear what Michelle and Chair Foster were discussing. But I think calling things what they are actually, it helps clarify and reduces confusion, because let me say there's a tremendous amount of confusion in all of this, this whole endeavor. Thank you.
Thank you for your comment. Any other public comment at this time? Mr. Berman, I've been asked in a number of hearings to remind folks if people are affiliated with any of the regulated entities. So I'll just introduce you, Mr. Berman, if you don't mind, as the CEO of OneCare.
Thank you, Chair Foster. And thank you for the opportunity to discuss the important work that we're all doing together with the public. I think the current environment, as we've all acknowledged, is really challenging for healthcare providers and hospitals in Vermont. And I think we're working together to try to help them through this challenging period and deliver better value for Vermonters. Some of the comments we've heard about the quality measure performance, I think reflects the struggles that they're having. I think OneCare and the all-payer model are in place to try and help these providers and drive improved outcomes for Vermonters. We have to acknowledge that the world is very different between 2018 and 2023. And some of the measure decline performance you're seeing are the struggles that healthcare providers are having, being understaffed and under budgeted to do the work they need to do. Unfortunately, the efforts of the ACO can't stem all tides. We're trying to work with the providers to do this work, but it should be remembered that the ACO really is the providers that are in the ACO. It's not a standalone entity as some other ACOs that are either affiliated with a for-profit entity or are trying to aggregate a tremendous volume of providers across the country together. These are Vermont providers coming together as part of the all-payer model to do this work. And I just want to be clear that the funding Vermont receives is not merely based on the existence of an ACO. The funds are part of the agreement because of the work that OneCare is doing and the measures that are in place. I think the healthcare advocate certainly is well-intentioned, and I appreciate their feedback. We want to do great work, and we want to work with them to address their concerns. Unfortunately, the measures they're introducing and they want to hold OneCare accountable to don't really make sense to me. I'm trying hard to understand them, and I listened very carefully when the gentleman from the Healthcare Advocate spoke. I don't know that they really mesh similar to what Member Walsh said with my understanding of what we're trying to do in the budget. It's really important when you look at ratios to consider what the relationship between the numerator and the denominator is and how you've gotten to those numbers and whether that's truly an indicator of what you're trying to measure. So just to be clear, I don't agree with those ratios. I think, as Member Walsh pointed out, page 25 of the presentation reflects the reality that I know that is in our budget. And I think it's really important also to think about correlation and causation. Just because you can draw a comparison doesn't necessarily mean that one thing caused the other. It's a difficult situation in Vermont. I think we all acknowledge that. I think we've got a good plan in our budget that we want to achieve on and measure ourselves on and have you measure us on as to whether we can do that good work and achieve improvements that are quantifiable in 2024. So just to sum up, I think we presented a reasonable and balanced budget that's going to allow us to support the goals of the all-payer model and help our participant network provide value to Vermonters in the coming year. It sustains the funding for the core population health management programs that we have, like CPR and the mental health screening. It also helps expand the use of waivers that cut through red tape for providers. And it puts more emphasis on quality measure and total cost of care performance than it has in prior years. As always, our team's going to work really hard to align incentives around the quintuple aim and break down barriers for providers as they seek to collaborate and innovate. And I just want to close by saying OneCare's operating budget and our population health management investments comply with the Green Mountain Care Board standards. This is very intentional. We take what the board says seriously. We tried to incorporate a lot of the recommendations that we've heard over the past 12 months into that budget, and I think it really reflects those efforts. When I read some of the recommended alternatives, I do take great pause. We put a lot of thought into how that budget's constructed, and if you evaluate it, I hope you take that into account and think about, as Member Lunge stated, what the ramifications of radical changes to that budget might be. So thank you for your time.
Thank you very much for your comment, Mr. Berman. Any other public comment at this time? Okay. Why don't we take a 15-minute break? We'll come back at 11:05. And we'll move on to the Medicare only ACOs at 11:05. Thank you.
Yeah, we'll go. So we were.
Are all the board members back on?
I see everybody.
Okay. Thanks. For whatever reason, I don't. Okay, we'll resume the Green Mountain Care Board's hearing of December 6th. I have a change to make, and I apologize for making it, but the agenda we had set out had the Medicare only ACOs scheduled for 1 p.m. Start, and we'd received significant public comment on the Medicare only ACO budgets, and I think it's 50 to 60, maybe over 60 public comments on it. And I don't see on the list of attendees some of the folks that were providing comment. And so I'm going to put the hearing in adjournment until 1 o'clock, just to make sure that everyone who wanted to attend and participate can attend and participate and make comment if they choose. So we will take a break again, and we will come back at 1 o'clock, and I hope everyone understands. I would love to plow through and finish and get through everything, but I think this is important to do. So we will adjourn until 1 o'clock. Thank you.